Blood Bank Guy Essentials 017.
So just quick note, if you don't remember anything else from this podcast, at least how it's taught, whenever you have a red cell transfusion, it never hurts to document that there's no evidence of hemolysis.
Yep.
Always ask for that.
Boy, I agree with that for sure.
And then you're covered.
Hi everyone, this is Joe Chaffin. Welcome to Blood Bank Guy Essentials episode 017. Today is an interview with Dr. Mark Fung from the University of Vermont. I wanted to let you know before we get started with that we've had a couple of really great episodes recently that have been downloaded in really large numbers, so thank you very much. The first is episode 016 with Dr. Jeannie Callum, where she gave us some great tips on how to use plasma in non-obvious situations. Really, really interesting stuff and fun stuff. She's a blast, so I hope you've had a chance to listen to that. That episode broke the first day record for downloads for my podcast. I also did a recent update on Zika virus. That is episode 015-1. And overall, in the first 4 months of this podcast, we just passed 12,500 overall downloads. So again, thank you very much. So on to today's interview. This is a discussion with Dr. Mark Fung about transfusion reactions. We're going to be discussing the how, the why, the where, and how to develop your own strategy for dealing with transfusion reactions. There's a lot of stuff to cover. So before I start, I should let you know that neither Mark nor I have any financial disclosures to give to you for this particular episode. I really think you're going to enjoy this. It's packed with practical tips. So with no further comment, I'm going to let you hear my interview with Dr. Mark Fung. All right, everyone. Welcome to Blood Bank Guy Essentials episode 017. I am still Joe Chaffin, and my guest today is the fabulous Dr. Mark Fung from the University of Vermont. Welcome, Mark.
Thank you, Joe.
I appreciate you being here, my friend. So I want to let everyone know a little bit about you. Gang, it's a real great honor to have Mark with me here today. Dr. Fung is an MD PhD who is a professor of pathology and lab medicine at the University of Vermont in the United States. He holds several roles there, including vice chair of quality and clinical affairs in his department, as well as the director of clinical labs at the University of Vermont Med Center. Mark did his undergrad and graduate school training at the University of Alabama at Birmingham, trained for pathology residency at Washington University and the University of Pittsburgh, and did his transfusion medicine fellowship at University of Pittsburgh as well. If the name sounds familiar, there's a pretty good chance that you've got a textbook sitting on your shelf, a nice, lovely green one that is the 18th edition of the AABB Technical Manual. And if you take a look at that, it's not fair to say that Mark wrote the book, but Mark is the editor-in-chief of the 18th edition of the Tech Manual, as well as the upcoming 19th edition. There's a whole lot more that I could tell you about Mark, including his roles in the BEST Collaborative, the Biomedical Excellence for Safer Transfusion, as well as the International Collaborative for Transfusion Medicine Guidelines. Published over 50, co-authored over 50 publications, et cetera, et cetera. Mark, dude, you're doing a lot of stuff, man.
Well, keeps me out of trouble.
Well, I would imagine so.
What do they say? They say idle time is the devil's time.
That's it. That is true. That is true, I guess. Well, so Mark, I always like to start off with my guests. You know, someone like you who is doing so much and has done so much in our field already, and I look at your pit and you're, you and I have not met each other personally, as far as I know anyway, but you're not an old guy. You've done a lot at a relatively young age, if I may say that. So let me ask you, how did you get involved with transfusion medicine? What was it that just kind of ticked the boxes for you when you were in training with transfusion medicine, and what keeps you there now?
Well, I just want to dispel the notion that I was born wanting to carry a bag of blood. I actually, when I started my rotation, my first blood bank rotation was as a fourth-year medical student, and I actually came to the conclusion when I was rotating in the blood bank that would be something I would never want to do. because I realized on morning call, resident after resident for each day on call would talk about how some unhappy surgeon was calling them in the middle of the night. And I said, why would I want to go to medical school just to be called every night by unhappy surgeon? That seemed
Yes.
hardly the career I wanted. But amazingly, I just got really, after going through my rotations, and I actually had the arrogance actually at the time when I was done with my 4 weeks of blood bank to say, that's pretty straightforward. I think even I could do this.
Nice.
And completely discounted the career altogether. But then somehow during residency, as I was going through all of my rotations, I came to realize, even though I was trained MD, PhD, I really just enjoyed the notion of being a physician, or at least I always joke about how I get to pretend to be a doctor in transfusion medicine. Really, I mean, it's the funniest thing. I was trained to what I call move little drops of water back and forth for molecular biology.
Right.
Look at cells under confocal fluorescence microscopy in vivo and all that lovely stuff. But I somehow enjoy the notion that the test that we rely on in blood bank is little red cells hugging each other in a glass tube.
Nice.
It's as low tech as you get. It's the only area where the Carl Landsteiner, the Nobel Prize winner from over 100 years ago, if he was in the blood bank right now, we could still employ him. How cool was that?
Uncle Carl. Come on, let's give Uncle Carl a job.
Yeah, so it's amazing. So despite, at the end of the day, despite all the technology, I really enjoy the human aspect of medicine in blood banking. We talk about healthcare and rationing of care. I said, you know what? We've been doing that in blood bank from the very beginning. Blood is a finite resource. We have to use it rationally. We have to push back on proper utilization. These are not new topics for those of us in blood bank. So it's been a really wonderful career in terms of training. And, my interests have changed over the years, and it's been able to grow with me and allow me to do different things as I move along. So I for those who love blood banking, good for you, but just be happy as well if you like other topics, in terms of the pursuit of a career. But it worked out for me. Who would have thought, my disdain would lead to a lifelong career?
So maybe that's the secret. Hate it at first and then you'll love it later. I don't know. There may be something there. Maybe not, though. So, Mark, that's fantastic. I think that you're right with the human and human interaction and medical aspect of it. I have nothing against my surgical pathology colleagues who, I did it myself for a large number of years. For me, that interaction, it's hard to replace. And I think that our topic for today actually kind of dovetails into that, because one of the places where blood bankers interact most often with clinicians is in the setting of the diagnosis, management, and prevention of transfusion reactions. And that is our topic for today. So let me ask you first, Mark, everybody's heard the phrase transfusion reactions. In your mind, when we say that, what do we mean? What are we talking about when we talk about someone having a transfusion reaction?
Sure. When we talk about transfusion reactions, I would always recommend that we change the narrative just a little bit. It's a suspected transfusion reaction. So anytime someone calls and says, I have a transfusion reaction, you respond like, tell me more about this suspected transfusion reaction. Because the reality is what they're really saying is that they think it's high on their differential or it needs to be excluded on the differential. And that's something you actually should ask them. Where do you see, reflect the question back to them, where do you see it in terms of its likelihood of being a transfusion reaction versus you just wanting me to rule it out?
Right. Okay. That's a great way to look at it. I think that does get missed quite a bit, and suspected versus confirmed. Well, but going further, so obviously it's something that happens during a transfusion, but I'm assuming there's a lot of pathways that those can take, right?
Correct. And so, the question then, now, thinking about the audience and thinking when I've been in your shoes, the first thing you always I'm always a practical guy. You always first have to ask, so what's your name and what's your pager number? There's nothing worse than hanging up on the phone, having a great conversation, and then realizing, oh, who was I talking to?
Oh, darn, yeah.
And who was that patient?
Good tip. Yes.
Happens to all of us at 3 a.m.
It does.
So, the questions that then come after the name of the person is then just timing. So by definition, implicit in a suspected transfusion reaction is what was the timing? Obviously, we get it. It has to occur after transfusion has started.
Right.
And so it goes from there. And then the question is how long after transfusion? We know that most of the reactions, by definition, if they are considered acute, are in the 24 hours or less window. Specific examples we can talk a little bit later using the CDC's criteria for biovigilance or hemovigilance have very specific time limits. So there are specific ones where we would say under 6 hours, but certainly there are ones when it comes to some of the transfusion-related infections or transmitted infections like hepatitis. We won't hear about this until much later.
Right.
So
right, and you just said something that's actually very important. I think to the average student, when they're thinking about transfusion reactions, they don't necessarily think about things like transfusion transmitted infections, aside from maybe the immediate bacterial contamination type stuff. But people forget that is a part of the overall categorization, just not necessarily the immediate one that people think of, right?
Correct. And I think one of the important things, particularly for our, what I call more general pathologists who work in the community, and they have to cover everything under the sun, which I'm very, grateful that there are people who are smart enough to do that. There is this wonderful opportunity where if you're suddenly being called about a hepatitis, result or an elevated LFT, liver function test, that you can then actually be able to say, "Ooh, wow, you know what? I know you're asking me about this question, but have you looked into just making sure that this patient hasn't had a transfusion?
Nice.
And is this at all possibility? Because we certainly have a means of going back and following up on whether or not that was at all a potential route of transmission." Good
call. Well, but I mean, to that point, just in terms of general incidence, I think I know the answer to this, but which kind of reaction is more common? The immediate stuff, the things that we think about that we'll get into later, the allergics and the febrile reactions, or the infectious stuff, the long-term infectious stuff?
Sure. I think this is a really important teaching point for our fellows and medical students, and even for all of us, because in the general public, most patients really focus on hepatitis or hepatitis B and C, but we know that those are actually quite uncommon in comparison to what we call the non-infectious types of reactions. And so, if anything, whenever we talk about risks, benefits, if there's a discussion, which we sometimes get involved in, we have to remind folks that, there are other things other than infections that we have to be mindful of in terms of complications for transfusions.
Good. Okay. And we can get into some of the specific numbers in terms of, the relative amounts, but, you know what? Let's just briefly hit that now, Mark, if you don't mind. So, I mean, just in terms of risk, when we talk about risks for hepatitis B, hepatitis C, HIV, et cetera, compare them to risks of reactions like allergic reactions, febrile reactions, transfusion-related acute lung injury. Can you discuss that for a second?
Sure. I think the key way to think about this is usually with hepatitis, C and HIV, we're talking well in excess of 1 in 2 million. Risk. Hepatitis A still is locking in at about 1 in a million. Hepatitis B really shouldn't be an issue because most of the population now have been immunized with against hepatitis B. But depending on who's your blood center, who's the supplier of the blood, whether they do additional molecular testing, it's at least 1 in 200,000 to 1 in 300,000 for hepatitis B. When we do talk about infections, those are the longer, so like in the future, you then need to develop a viral infection. We still are very much focused on the concern for bacterial infection, particularly with platelets. As some of the listeners know, platelets are stored at room temperature in a bag that's shaking on an incubator. You would think we were in the microbiology lab with a bag of culture there.
Sure.
So that risk runs closer to about, I would say we currently cite somewhere in the 1 in 30,000 to 1 in 75,000. I think we're starting to go towards more of the 1 in 75,000 with all the additional measures we've put in place for looking for risk of, we screen for contamination of bacterial infection. We've now improved our sort of skin prep when we draw blood in general, and there are other neat things we do. Something as simple as just the plug of skin that comes out when you give someone a tiny skin core biopsy when you put a needle into their antecubital fossa. The first, I don't know how many mils of it goes into a diversion pouch that they can use for testing, but yet it also carries away, flushes out any microorganisms that were not killed with the initial scrub of the skin. We know from the literature that drops it by at least 50%, that rate. So that leaves you then with the more common reactions, which are, allergic reactions. Hives and what I call chills are probably on the order of, in the percentages, 1 to 5%, depending on the population that you have. But those are, usually just uncomfortable reactions. People do also worry about, well, what about, severe allergic or anaphylactic reactions? And that's probably more in the 1 in 2,000 to 1 in 30,000 range. I think of the non-infectious complications, which the patients never think about, are things like, respiratory reactions, whether they're fluid overload, or a transfusion-related acute lung injury. I mean, one of the observations over the years is that fluid overload is becoming more and more prevalent and recognized as a legitimate transfusion reaction. People forget that, and I know you know, Joe, that a bag of blood is really full of colloid solution. And so it exerts a very different oncotic pressure. You can't exactly pee out the excess volume of plasma like you would a crystalloid like saline or lactate ringers. Yeah.
Well, I have to tell you, Mark, all of that is great info. Because I'm a goofball, I'm very pleased that you didn't use the other phrase for circulatory overload. So thank you for not saying that. That acronym drives me crazy. Everyone, just in case you're wondering, I'm talking about TACO, which is insane. Anyway, sorry, we'll talk about that later. All right. So, Mark, thank you for that. I think that's really important. So, but as we go through this, I'm interested in your take on just how we define these things. I mean, obviously, you can go through any number of blood bank textbooks, including the one that you edited, the AABB Technical Manual, and you'll see categorizations and classifications of different transfusion reactions. So I'm wondering, how are we doing in the United States with standardizing, or is there a way to standardize the definitions for these transfusion reactions?
Sure. So with regards to standardization, there has been a movement afoot for the U.S. to finally join the rest of the world with having defined transfusion reactions in terms of, a criteria for meeting a specific transfusion reaction class category. We're unfortunately one of the later, if not the last country. But hey, it's like buying a particular smartphone, the latest version, without having to buy all the earlier ones, I guess.
There you go.
But so certainly the CDC had worked with the AABB very early on. I've lost track of how many years ago now, to look at the ones that were developed by ISBT. This is the International Society for Blood Transfusion. This is the International Blood Bank Society, something like that in French. I forget how it gets pronounced, but they already had in place draft guidelines that we then subsequently adopted for the most part and brought into the U.S. And so that was developed mainly for public health and epidemiology purposes, so we can monitor public health policies around transfusion safety. But one of the things that came out of it was that this now allowed for us to have standardized language and terminology for how to call a transfusion reaction in terms of the different shades of it being likely a transfusion reaction, not related to a transfusion reaction. And we will talk a little bit, hopefully a little bit more about it later on, about definition criteria versus the relationship to transfusion. So the CDC document, which has been produced by the, if you have to look online, it's the National Healthcare Safety Network, or NHSN, has a hemovigilance module specifically on transfusion reactions. And there's the most recent version came out June of this year, and it has in it a criteria that I'm more than happy to sort of give your audience just even a quick run through. But even before you go through this thing, and I think about my colleagues, and I went through anatomic pathology training when you first looked at glass slides, and you're like, well, what am I looking at? And you don't know what you're looking at, so then you wallpaper is what we used to call it. You just put up different images of different tumors, and so you say, this matches. I mean, you could kind of potentially do the same thing with this one as well, taking the different transfusion reactions and see which one fits. But certainly I would encourage the listeners to take, and I bet most of the audience take a more sort of systematic approach. Right. The classic one, which I use and I adopted in my own teaching from Nancy Hedl out of McMaster, is to create a table for yourself. And if I can get some permission from Nancy, I'll share with you all my adaptation of that. But even in the absence of that, I would argue it's a good learning exercise to just list out all the different transfusion reaction categories that you think exists on like a grid on the far left, and then across the top put down skin, inflammatory and fever chills, pain, respiratory, cardiovascular / hypotension, then cardiovascular / hypertension versus hypotension, and then GI / jaundice, and then just put in little X's where you think where each of these transfusion reaction categories might have particular system of presentation. And I always remind everyone I work with that, the problem a lot of times with textbooks is they present them as transfusion reaction categories. But the last time I checked, when a patient presents to me, they don't have like a little index card or written on their forehead saying, I have this reaction, now treat me.
Right.
They present with signs and symptoms. So what I would do is create columns of signs and symptoms. And then for each of these reaction types, whether it's allergic, I have allergic mild, allergic severe, hemolytic, acute hemolytic, delayed hemolytic, hypotensive, febrile non-hemolytic transfusion reaction, transfusion-associated circulatory overload, transfusion-associated dyspnea, which we can talk a little bit about, transfusion-associated graft-versus-host disease, transfusion-related acute lung injury, and then bacterial contamination. And then with that grid set up with the Y and X axis, just put in the X marks, and just going through that exercise, I think, will help you to sort of firm up your sensibility about what are the different reactions that I should think of in my differential.
And I think, I beg your pardon, Mark. I'm sorry. Go ahead.
No, I was just going to put in a plug. Certainly, what the AABB in collaboration with John Roback from Emory and his resident put together, which was this nice little program called TRDDX. I think if you look on the trddx.com, I think you will come across. They'll point you back to the AABB webpage, where there's even a web app where it'll run you through a series of questions to sort of help you narrow down your differential. And that's just to share with the audience. That is something that the AABB and I, and working with others on the hemovigilance committee, are checking out, and with some of the participants in the AABB Patient Safety Organization, testing out that algorithm to see if it helps our colleagues in narrowing down the transfusion reactions. But I would argue fundamentally, if you have a patient that has a respiratory reaction of whatever type, by definition, if you set up that grid properly, you're going to say to yourself, okay, if I have my grid and I put in the axis, then it could be allergic, it could be circulatory overload, it could be transfusion-related acute lung injury, or transfusion, and then a transfusion-associated dyspnea that the CDC and the NHSN put together as sort of your other category, like respiratory reactions that don't fit into some obvious category.
Right.
And then the last one, sometimes people forget, is a bacterial contamination. Uncommonly can also cause a respiratory reaction. So that's what I've done for myself, and what I share with my residents is we put together a little table, and that's our table for generating a differential diagnosis.
That's so. What I was going to say is that we are going to seek permission from Nancy to put that on the Blood Bank Guy site. Your adaptation of her original categorization, but I think it's really what you said is really important. That those of you that are students that are listening to this. Don't just take what Mark did or what we're able to put on the site and replicate it and shoot a copy of it and put it in your folder, but actually going through the exercise of doing it yourself, I think is hugely important to help you solidify that. So that'll be on the website, and the link to the AABB the transfusion differential diagnosis module will be on the website as well, Mark. So we'll have those available for the listeners. Going back to the CDC NHSN National Healthcare Safety Network, that's generated a lot of conversation in recent months in terms of people trying to understand how it fits in with what we're doing with transfusion reactions. So let me just ask: is this? I know in some countries it's mandatory that transfusion reactions are required. Are we at that point in the United States? Is reporting to the NHSN required in the U.S. right now?
Reporting to the NHSN is not required. I would point out that there is a requirement with the AABB standards, which has a requirement for standardized definitions for adverse reactions. And I think we were very careful about this. You can blame me for pushing this, but I felt we were not going to force folks to use the NHSN definitions per se, but at minimum, we felt that facilities, and even if you're not an AABB member, I think it just makes a lot of sense to just have, in your transfusion administration policy, just some kind of, guidelines as to how a reaction is defined, so that at least you and the clinicians can have common language and consistent language when talking about transfusion reactions.
That's true. And Mark is referring everyone to Standard 7.3 in the 30th edition of AABB Standards, which I'll just read it to you. It says, the blood bank transfusion service shall use standardized definitions to classify donor and patient adverse events. So again, you're driving at, AABB is driving at standardizing, at least in your own facility, not necessarily standardized with everyone else, but obviously, the NHSN criteria give you an opportunity to use those to standardize, right?
Yeah, the way I would put in the plug for the NHSN criteria is that we did the homework for you. You can just say, here's something that's available for free, pre-baked. You don't have to go through a committee to work out the kinks. just use it. Please use it. So that it would be easier, obviously. They're not perfect, but it's a good start.
So, Mark, forgive me for interrupting, I'm sorry, but if you do decide to standardize to using that, does that commit you to reporting to NHSN?
The good news is it does not. There are a number of facilities that I've heard that have adopted the NHSN definition guidelines and criteria without reporting into CDC. We think they should consider reporting into the CDC, because then that allows them to then benchmark and participate in the discussions with other hospitals in terms of the challenges they have with trying to classify reactions or looking at their rates of reactions. Right.
Okay. So, and I think I may have heard you say this at some point before, that if you're gonna standardize, if you're gonna use the criteria anyway, I mean, you've done most of the work that's required for reporting, so it might be something to consider. But I guess the key is that it doesn't necessarily commit you, and there's no financial cost to using those guidelines. Correct?
Correct. There is, I think, the submission to what you will realize is most hospitals already have an NHSN account with the CDC, because their infectious disease arm is already participating with with reporting of infections. And so since that's already in the system, it's just literally just turning on an extra module within and adding your name to the system.
Got it. So, Mark, you said just a second ago that, and I have you on record now, I have you on recording that the NHSN criteria are not perfect. So I'll hold you to that, my friend. Well, I won't ask you to be specific, but it is important to recognize this, that there are a number of reactions that are defined by NHSN. I believe it's 12 if I can count correctly, which is a challenge for me sometimes. But to your knowledge, is there anything missing from any major reactions that people are talking about now that are not included in those 12?
The one that has come up periodically and more in the neonatal group has been the reaction around necrotizing enterocolitis associated with transfusions. We've heard some people are really into the acronyms. I think I've heard one called TRAGI or something like that, transfusion-related acute gut injury or ischemia.
Right.
And we went back and forth on it, and at the time we had chosen not to include it. Now I would just point out, this is back in the days when I was involved with when AABB and CDC were collaborating and designing. At this point, CDC has wholesale owned it now.
Got it.
In terms of its updating of the guidelines and the criteria. So that's not in there, but we certainly have always said to folks that there are ways to code it under the other or unknown categories of it. So if the day comes when there's enough of a bio literature, those who are substantially interested in it, I think, should consider approaching the CDC and asking if this could be reconsidered to put it up as an additional category. Okay.
Well, how about the ones that are included, Mark? There are what I've seen in facilities that are implementing these criteria. The two questions that I get, the two reactions that I get asked about most commonly are, I'll just tell you how the question generally goes. It's normally, Joe, I've never heard of a hypotensive transfusion reaction, and I've never heard of transfusion-associated dyspnea. Can you talk just a little bit about both of those? Because I don't think we'll hit much of those later on as we go through some cases.
Sure. So, transfusion-associated dyspnea, the way to think about it is it really is if it doesn't fit any of the other classifications for a transfusion reaction that has a respiratory component as its major aspect of that suspected. Remember, suspected transfusion reaction.
Right.
So basically what that means is you got a patient that's in respiratory distress, but they don't fit precisely with transfusion-associated circulatory overload, and they don't fit perfectly with transfusion-related acute lung injury. So where do you put it? You still want to capture it. And so you would put it under transfusion-associated dyspnea. Okay. So similarly with hypotensive transfusion reaction, we know that when it comes to a hypotensive reaction, there are a number of possibilities. You would have had to rule out usually if it's a red cell transfusion, we would want to rule out hemolytic transfusion reaction. So just quick note, if you don't remember anything else from this podcast, at least how I was taught, whenever you have a red cell transfusion, it never hurts to document that there's no evidence of hemolysis.
Yep.
Always ask for that.
Boy, I agree with that for sure.
And then you're covered. But regarding the circulatory reaction, so if you have a hypotensive transfusion reaction, your choices really boil down to whether it's a severe allergic reaction, a hemolytic reaction, even transfusion-related acute lung injury or trolley, bacterial contamination. Those are the ones that come up in the differential. And if it doesn't fit those four, and you feel really confident about it, then you really wind up then with the hypotensive transfusion reaction. I think I'll give you a classic one. It's interesting to hear that some folks don't know what to do with it. We have these patients on the cardiovascular service who are on vagolytics, and so they're vasodilated. They come out into post-op, and you turn on a blood transfusion and the blood pressure drops. It really drops. Yeah. And then when they stop the blood, the pressure comes back up. You start again, it drops. You stop, it comes back up. You're like, I feel confident it's transfusion related. Yes. But as for a reaction, I really have no idea. You know, I
Right.
do the ABO check, I do the hemolysis check, and I shrug my shoulders and say, "Yep, it's not hemolysis, but I'm not sure what it is." You know, the one thing I noticed that we did not include in these reactions, which is a classic one, but I want to make sure that the audience is aware of, is what we call vasovagal reaction. For whatever reasons, I've come to appreciate we never included. I guess hypotensive transfusion reactions can include vasovagal reactions. It's something I want the audience to be aware of, particularly for the medical students. We often see this more frequently in donations, not so much in transfusions, but this is in the hallmark of that one. I just want to spend a couple minutes on that because we don't talk about it in the criteria in these guidelines. Is this is basically someone whose blood pressure drops, and yet paradoxically their heart rate does not increase to compensate for that drop in blood pressure. That's usually a hallmark for us of a vasovagal reaction. So that's something just to keep in mind. So again, this is an example where these categories are not completely perfect. The other one that always is a challenge for us is respiratory reactions. If you were to look in these CDC guidelines, they would want you, before you can call someone with having transfusion-related acute lung injury, you have to have excluded the possibility of circulatory overload. But we also know clinically you can have both simultaneously. And so it's not perfect because it was suggested you have to have one excluded over the other. Now, clinically speaking, when I have a respiratory reaction, and we can jump around a little bit. Since we're talking about respiratory reactions, let's take your 80-year-old man who's got a history of congestive heart failure. He's getting, his second unit of red cell transfusions, and then he develops, shortness of breath. His lungs start getting a little gurgly, and you ask yourself, well, which is it? Is it circulatory overload? Is it transfusion-related acute lung injury? The good news is usually you can figure that out pretty quickly, because what you try to do is you try to deal with the circulatory overload if that is a potential component. And if it goes away with diuresis or dialysis, and the patient then, his respiratory status improves within the 24-hour time frame, I feel pretty confident that it's most likely circulatory overload. But if, on the other hand, you've done all the things that would have addressed circulatory overload, and you still have, someone who's got wet lungs, then you have to then ask, okay, it's more than circulatory overload. There's some kind of acute lung injury. And so that's one thing I want to emphasize to folks, So here's the bad news, audience. Textbooks and guidelines and criteria can only get you so far. You still have to say, oh, wow, I went to school for 4 years in medical school, and I hopefully picked up in some undescribable way clinical logic to say, there are things that they don't teach you. You just kind of have to figure out.
Yes, and that is one of them. I say the same thing to residents. Just because one thing is happening doesn't mean another thing can't happen as well. So one more question on the NHSN criteria, Mark, because I think this is, and I know we've spent a long time on this, folks. We will get to the cases in just a second, I promise. But this one we've got to talk about, because there is so much confusion about this in the NHSN document. When you look at it, you're supposed to assign 3 things to each suspected transfusion reaction, and the first is the definition, possible, definite, probable, possible. Those categories don't always apply to every reaction, but generally speaking, the severity and the imputability. And man, Mark, there's so much confusion, especially about the difference between definition and imputability. So can you help us understand that?
Sure. I wish, Joe, in hindsight, that we had used a different word than imputability. The way I think of imputability is relationship to transfusion. So, in fact, when I write my notes we have in our template, I always have to add in parentheses after the word imputability, I write in parentheses relationship to transfusion. So this is going to be a conceptual breakthrough. for us in transfusion medicine. We're going to have two variables to describe a transfusion reaction beyond
Right.
severity. So the definition criteria is really about how classic is the presentation of this suspected reaction. And all the signs and symptoms and the timing really sort of perfect for a transfusion reaction. But here's the kicker. This is irrespective of any other potential causes for those same signs and symptoms. It's just asking, is this a classic presentation?
Right.
And so then you answer that question separately. And then the second part, imputability, is really about, okay, regardless of how well it fits, is there any other reason I could have had these signs and symptoms? And so I'll use one that's clearly imputability. And so let's say, every once we hear about this purple nose syndrome, right? So you have purple nose, and every time you start a blood transfusion, you get a purple nose. And every time you stop the transfusion, the purple nose goes away. Uh-huh. And so with that kind of scenario, I feel pretty confident that the imputability is definite. Uh-huh. You stop the transfusion, you started it, and you still have a purple nose. It goes away when you stop it, right? So no problem there. But in terms of criteria for case definition, there's none. There is we don't have it in the CDC, purple nose syndrome. Mm-hmm. And so that's a classic one. Alternatively, you have a patient that's getting a transfusion that has pneumonia. Mm-hmm. And as you're giving the blood, the temperature starts rising through the roof, but you also know that, oh, by the way, the patient spikes, for whatever reasons, every night for the past 2 nights, regardless of whether they get blood transfusion or not. Now, you could say, well, it's a red cell transfusion. I did my hemolysis check, and the hemolysis check was negative. And so you could potentially say, wow, it fits the case definition criteria for febrile non-hemolytic transfusion reaction. And so the way that gets reported out for us is we would say diagnosis suspected, or you could just say febrile non-hemolytic transfusion reaction. Let's say the severity was mild, non-severe. Mm-hmm. But then under imputability, you would say, doubtful. That's one of the choices. You say doubtful, and put in parentheses or dash. Patient has a history of ongoing pneumonia. The temperature rise was occurring before start of transfusion, and we don't think it is. Or if you're not certain, because you notice that when you stop the transfusion, the temperature went back down a little bit, you can use possible, meaning we couldn't fully exclude it. So that's the power of sort of getting away from, back in the days, before we had what I call two-dimensional descriptions of transfusion reactions, we would just say, I don't know, I had this possible reaction. Well, what do you mean? Are you saying possible because it didn't fit perfectly, or possible because there are other causes for the signs and symptoms? And so that's, I think, a key contribution. If nothing else, I think the imputability is a very important concept. I've joked to some of my colleagues about how I just need to write an editorial with Jim Albenchon and Barbie Whitaker, just explaining the imputability, because I think it's important for us to add this extra dimension to transfusion reactions.
Well, so Mark, I think that's very helpful. Let me ask you this though: what happens in that last situation that you were describing, where you've given a quote unquote definite to febrile non-hemolytic, but you've put doubtful in the imputability? When the clinician calls and says, "What does this mean, Mark? Is this a febrile reaction or not?" What do you say?
I say both things. I say the classic definition of the presentation fits, but we have, in terms of the relationship to the transfusion, there are other things timing-wise that could have just as equally contributed to it, and either is a possibility or is doubtful, depending on the sort of the clinical judgment of the team.
Okay. I understand. Okay, well, I think again that's really helpful because I believe me, I'm sure you do as well. I get a lot of questions about that particular thing. Okay, so what I would like to do, Mark, with your permission, is to go through just 3 or 4 cases or so that illustrate. I'd like for folks to just get an idea of how to approach these reactions and kind of your method and mechanism for doing this. Again, Mark uses and teaches a grid based on work that Nancy Heddle has done that he described earlier in the podcast. One thing we haven't talked about, Mark, is the second part of your grid where you describe the possible tests and evaluations to consider. And I'm hopeful that we'll have that on the website as well. It kind of takes you from just the basic transfusion reaction workup that everyone thinks of, the ABO type, the direct antiglobulin test, the hemolysis check, and the clerical check, and it expands that to include other things that you might think of depending on what the signs and symptoms are. So again, I don't think we have time to go over that in specific detail, but we'll try and get that on the site, and I think you'll be referring to that as we go through these cases. So is that fair enough to start with a couple cases now, Mark?
Absolutely, and I'll just identify for the audience, if they want to go through the learning exercise of constructing it for themselves, the categories along the top of the grid are the original signs and symptoms by the various, skin, inflammatory, pain, respiratory, cardiovascular, hypo, and then cardiovascular hyper, and then the last one is GI or jaundice, and then on the left-hand side, the rows would be, your hemolysis check, your ABO, DAT, a repeat antibody screen, a chest X-ray, a B natriuretic peptide for fluid overload, bacterial culture of patient and product, review of fluid status or balance of the patient, repeat a CDC, a CBC to rule out bleeding, and then IgA levels or anti-IgA. I mean, the reality is the funny business about blood bank is we only have so many choices. I always joke, blood bank is easy, right? You start with the basic premise of, is blood available? If it's not, you know what you need to do. If blood is available, the next question is it compatible? And if it's not, you then talk to the clinician about how badly do you want it and need it.
Yes.
So I always feel, maybe the reason it fits my nature is that it's a pretty simplistic structure to start with. I mean, don't get me wrong, it gets complex in a hurry. But let's go ahead and talk about, I'll use a simple case. Classic 85-year-old female, lung cancer, COPD. She's anemic, so she gets 1 unit of red cells. And then she complains of itchiness, gets her diphenhydramine, which is an antihistamine, 25 mg IV times 1, continues to itch, develops a rash on the abdomen, and hopefully you've done the things that you should have done already or asked for from the nurse. And remember, actually, it's the nurse who's at the bedside, not the intern, usually. So I always talk to the nurse first, just my own practical advice. And you find out that the patient's got, 1 degree rise. It went from 36.7 to 37.7. Blood pressure went up a little bit, up to 100, systolic from 106 to 113. Diastolic was fine. Heart rate went up 102 to 109. The respiratory rate was about the same. And then the question is, well, what would you call it? And I've given enough information, to make someone get confused in a hurry. The temperature went up a degree. Should this be called a febrile, reaction, assuming we can rule out hemolysis for the red cell transfusion? The blood pressure went up a little bit. What word to call it. And, this is where I say, okay, remember why the patient was called to attention. This was itchiness. And we know itchiness is associated with, usually an allergic reaction. But we would then go through the grid and say, okay, it's a skin manifestation. And so what are the things I should worry about? Skin reaction, almost always we think of, allergic reactions. I mean, could it be a hypotensive reaction? The skin start modeling. Sure, but less likely. Could it be transfusion-associated graft versus host disease because you do see skin changes? Sure, but that's a different time frame.
Right.
And so at least for skin manifestations, usually I don't do anything because I feel pretty confident that we're looking at a mild allergic reaction. We would diagnose it as such as allergic reaction. The case definition criteria, depending on if they have at least 2 signs, would make it definite. If it's only one of the on the list that the CDC uses, then we would call it probable. The severity be non-severe. And imputability, assuming there were no other reasons for this patient to develop an allergic reaction, such as other drugs being given at the same time that can cause a reaction, we probably would sign this out as definite. The treatment, as most of you know, we would then just treat symptomatically with your antihistamine of choice, whether it's diphenhydramine or otherwise. Those are the easy ones, I would say.
Yeah. And as I think you and I both know, that many of these we never hear about. They just handle them on their own, and I'm not sure that's I don't think that is at all the worst thing in the world, but I'm pretty sure those are underreported.
Correct. And what I actually in our hospital, in our blood bank, what we do is we tell the nurses and the staff, and we have actually in our policy that they don't have to call blood bank for that. They just have to record it. The way our transfusion documentation works is the blood bank gets a back copy of the ticket attached to the unit, and so they can just record that there was a hive reaction.
Got it.
And we're done.
Yeah, nice. Then
so that's easy.
So the one kicker to that case, Mark, that I'll push back on you a little bit, is the increase in temperature. And obviously when we talked before about things that happen don't necessarily have to be related, but normally you don't think of an allergic reaction having a temperature increase. Do you have any comment on that?
Sure. The good news is this is where I will just rely on the CDC criteria and say that at least with the CDC criteria, you have to be 38 degrees or higher, and so we don't meet that criteria, so we don't have to worry about it, and just say it didn't meet criteria, it didn't reach 38 degrees,
right?
Even to qualify, This is a key one because we often have this situation where patients are coming out of the cardiac surgery suite and they're chilled, and so by definition they're going to be like at 35, and so we would be calling febrile reactions on all of them.
Yep. No, that's very true. And that's the point that I wanted to make sure we hit, is that, when someone starts low, and they increase, it may be something, but most likely it's not. I don't know. I kind of go back and forth on this, Mark. I am on record as saying that if there's doubt, I really don't have any problem in a scenario like that doing a basic hemolysis workup. I really don't. I don't have any heartache doing an extra one if someone should send it for workup in a case like this. But I agree with you in this case, when it was low to start with and stayed below 38, it's probably not a big deal.
Yeah, I agree with you that the threshold for us to do a hemolysis check is very low. And what I usually tell folks is, just check the ABO. That's the first thing. If there are two things that you have available to you, first of all, you know what unit you gave out. And if it's a Group O unit, you ruled out the vast majority of the worrisome ABO incompatibilities. Even if the patient's ABO was the wrong type, you've given them Group O blood.
Right.
Could it be possible that it was some unforeseen rare hemolytic reaction because of some missed antibody? We've looked in the data. It's upwards of in 1 in 10,000 or higher, that kind of chance. This is back in the days when we thought we had to cross match and do a full cross match of blood versus what we do now, which is if the antibody screen is negative, we do a more abbreviated immediate spin or abbreviated cross match, which is a lot faster. And so, that piece helps. The other piece I always tell residents is, for your patient that has a Foley, just look at the urine and see what's coming out of the urine bag. If it's clear, then it's not, there's no hemolysis, So there are a lot of things you can do.
I agree. Okay, so I think that's a good look at a mild allergic reaction. Why don't we go on to case number 2, Mark?
77-year-old female who states, "I don't feel good all over." Plenty of patients throughout the U.S. that have that presentation. Chest pain, back pain while receiving red cell transfusion. Also has nausea. No urticaria, so no hives. Known to the blood bank due to having antibodies, a combination anti-K or KEL and an anti-JKA from the KIT system. And so the question is, what do you do next? We, of course, always look at vital signs. And in this case, this patient already had a low-grade fever, 99.8, went up 0.2 to 100 degrees, 0.0, so no real change in temperature. Although it technically, by CDC criteria, if it was to go higher, we're in the ballpark. So febrile reactions require both, by CDC criteria, 38 degrees centigrade plus a degree on top of that, or 100 degrees Fahrenheit. So this patient is right at threshold, but really not much of a change.
Right.
The next vital is heart rate went from 66, climbed up to 80. Respiratory rate climbed up from 20 to 25. Blood pressure also climbed up from systolic of 143 to 167. The diastolic went from 75 to 103. Otherwise, lungs are clear, no asthma, good O2 sats. And so, the question then is, what do you do with this one?
Yeah.
And at least with this one, I think of, it's really, the presentation is about pain. And so when you think of pain, going through the list of the different transfusion reaction possibilities, an acute hemolytic reaction comes to mind, potentially a delayed hemolytic transfusion reaction, but I usually think of an acute hemolytic transfusion reaction. A febrile non-hemolytic transfusion reaction can also induce some pain as well. The Mark Popovsky's transfusion reaction book in the past actually has identified a distinct entity around pain, which I won't go into, but there's some literature on that as well. Very small literature. So under the pain category, because I'm concerned about a hemolytic reaction and potential for febrile reaction, it actually triggers me to do a couple things. I do the hemolysis check. I also look for bacterial contamination, so I might culture the patient or culture the unit if the unit's still available, in addition to my ABO, just to sort of cover myself for this reaction. That's a particularly unusual one, but that's what we would do sometimes. But underlying any red cell transfusion, as we've talked about, anything that's more than a hive or an obvious circulatory overload, I think it's incumbent upon us to ask the question and answer it definitively. Was there hemolysis or not hemolysis? Just get that squared away.
Yeah, you bet.
In this case, everything was fine. What else I asked for in these kinds of reactions, even though the patient was relatively afebrile, and this is where, I'm sorry, my brethren in the blood banking community, we don't always use the best choice of words for transfusion reactions. I'll refer to the entity known as an afebrile non-hemolytic transfusion reaction.
Yes.
And so a lot of times, I don't know about you, but I feel like a dope when I explain to the team that I'm going to call it a febrile non-hemolytic transfusion reaction, but they say, but the patient has no fever. And what I remind folks is that, the ideology behind a febrile non-hemolytic transfusion reaction is one of an inflammatory type of reaction. And so it doesn't always have to have a fever. You can have pain, you can have chills, rigors. So we often do see, I suspect many in the audience have had afebrile chill reactions, and they're like, oh, what am I going to call it? A lot of times what I'll do is I'll call it exactly that. I'll call it a febrile non-hemolytic transfusion reaction, and I have to put in a little disclaimer to say, this reaction, although is the patient's afebrile, the other symptoms and the lack of hemolysis fits best pathophysiologically with the category of a febrile non-hemolytic transfusion reaction. And that's particularly important for those around the country, although there aren't as many facilities that use non-leukocyte reduced blood, but to ask the question then, is this a patient that if they have repeated reactions that are afebrile, but they have these pains or they have these chills or rigors, that they probably should use leukocyte reduced blood.
Yeah. Okay. And there's a lot more that we could discuss about febrile non-hemolytic reactions, their pathophysiology, and all the things around that. You've already mentioned the use of leukocyte reduced blood products will certainly decrease their incidence in most cases. Pre-medication, a lot of arguments back and forth about that. But in the interest of time, Mark, I think you've you've covered it pretty well. Why don't we move on to case 3, because that's one that cases 3 and 4 I think are really important for folks to get a good handle on, because that's something that people do struggle with, especially the distinction between the two entities in cases 3 and 4. So let's go for it.
One thing just on that previous case, always ask the question whenever there's a febrile reaction, ask the question whether or not the patient is clinically suspicious for sepsis, because you do want to make sure you don't miss that. It's uncommon amongst us, but it's something to ask. So case 3, 57-year-old woman with pancytopenia and acute myelogenous leukemia, or AML, received a platelet transfusion prior to placement of a central line, and then developed severe shortness of breath. She's got mottled skin, heart rates jumped to 120, she's hypotensive, she's got a high respiratory rate of 40, and her O2 sats dropped down to 70%.
Ouch.
The things immediately is we're going down the respiratory differential. So the things that come up would be allergic reaction, circulatory overload, transfusion-related acute lung injury, and we put in there also, in case we don't rule out transfusion-associated dyspnea, if we can't fit it into either of the two. Then the final category would be bacterial contamination, are the things that come to mind. Those are all the things that you then would want to evaluate for. So we would, because it's unlikely, with a respiratory reaction, some facilities will say, just in case, let me do that ABO, rule out with the platelets, but it's unusual, but it won't hurt. I think the key constellation of things you want to do would be a chest x-ray. If there's any concern about contamination, you need to culture both the patient and the product. If you're thinking about fluid overload, the two things that come to mind is the B natriuretic peptide, or the BNP, and looking at the patient's fluid status.
So, Mark, let me interrupt you for just a second, just to make sure that everyone's clear. Give me the thumbnail on BNP and what it detects.
Sure, we've known that the BNP is a peptide that's actually released from the atrium when there's distension of the atrium of the heart, and so it's been a known marker for congestive heart failure. And so what we've done in our communities, we've used. Usually people look for at least a 1.5 to doubling of the BNP levels from baseline as a marker of fluid overload. It's not perfect. I just want to point out to the audience that any patient that has renal failure likely already has an elevated BNP. So it's not like you can just order the BNP and wow, you got your answer there. I still have to go to looking at fluid balance, looking at rates of fluid transfusions.
It's a tool, in other words. It's one arrow in your arsenal, correct. I guess. You could look at it that way.
Correct.
Okay. Sorry about that, Mark. Didn't mean to interrupt you. Go right ahead. So and so we then go down and do the chest x-ray, and let's say this patient has, diffuse interstitial infiltrates, and so you're kind of going, wow, this looks like it could be transfusion-related acute lung injury. Could it still be fluid overload? Let's assume you were able to rule out fluid overload. Part of that usually is you have to look at the blood pressure, and if I have a patient that's hypotensive, then I'm not really looking at fluid overload. So it really tilts me down towards, whether it's contamination and or transfusion-related acute lung injury. The cultures would have been done, and we would know within 24 hours if that was the case. I mean, the treatment for this patient is purely supportive. This patient is going to get intubated with an O2 sat of 70%. The money is going to be that there's a concern that it's acute lung, transfusion-related acute lung injury, and then that's the path that we go down. Usually, what I recommend when you have that situation is you make sure you grab a sample to allow for potential HLA typing of the patient. Usually it's a lavender top for molecular studies, and then you contact your blood center because what they'll want to do is they want to sort of pull that donor and see if that donor has any possibility of having leukocyte antibodies. It's becoming less of a concern as many of the blood centers, if not all of the blood centers, have started implementing different types of screening assays to reduce that risk. Right, right. And are required to, as a matter of fact, by AABB standards. I think that's next month, right? When
it's coming up, but
goes
as
into
we
place.
know, not all of the reactions associated with transfusion-related acute lung injury have been associated with antibodies. There is, Robert Silliman's heavy work around the notion that it could be some other they call biologic response modifier, which is, I always think of it as a fancy term for we're not sure about something in the blood.
Yes, indeed. Okay. So, I mean, I think what you've described is a fairly classic case of transfusion-related acute lung injury. Just to close out this case and get to the next one, how, as you said, this is supportive treatment, and there's a lot that goes into the diagnosis that we don't have time to talk about today. But how do people do generally when they have transfusion-related acute lung injury?
The mortality associated with it is roughly around 20%. I think the challenge is if they are supported and they aren't completely drowning in their fluids and they're able to, the way to remember with acute lung injury here is that you've basically opened up the pores, so to speak, between the barrier between the alveolar space and the capillaries, and fluids just pouring in. I think of them interchangeably. You have your fluid overload, I think, which is the next case, and transfusion-related acute lung injury. I think of just like a big dam, water on one side. And what I think of is when you have acute lung injury, you break that dam and water just pours through. In contrast with fluid overload, you have too much fluid and you go over the dam, is the way I think of it.
Yeah. Oh, nice. Nice. That's a great way to look at it. Good call. One other thing before we leave this entity, one of the things that I think residents hear from time to time, and blood bank staff, is about someone who was transfused, say, 10, 12, 18 hours ago, and now has a respiratory issue, and they want you to work up the case for transfusion-related acute lung injury. Is there a timing issue that we should be concerned about with that diagnosis?
I mean, that's where I tend to just go straight to the guidelines in terms of, this is another example of where having guidelines really help you. Right now, we usually say for transfusion-related acute lung injury that the onset is during or within 6 hours of cessation of transfusion. So that's pretty far out. There are cases in the literature that have been assigned the diagnosis of a transfusion-related acute lung injury, but the likelihood diminishes in a hurry once you go outside the 6 hour mark. So it's not impossible, but you then have to start thinking about other possibilities in your differential diagnosis.
Excellent. Yeah, that's important to remember. It's typically a very acute reaction. So, all right, Mark. So, great discussion. Again, there's a lot more that we could say about that, but we're nearing the end of our time together. So, I want to make sure we get to this last case if we can.
Sure.
Go for it.
48-year-old male receiving red cells, complains of shortness of breath, and let's just cut to chase. Negative DAT, no visible hemolysis. Clerical check was okay. You do your pre and post vital signs. Afebrile. The key vital sign change is that your blood pressure went from 145/82 to 161/88. There's like a gimme to say, gee, guess what we have here? The low challenge here is the heart rate went up just a little bit, 72 to 78. One thing as a side, this is where, even though I joke about how blood bank is easy, it can get tough. We know sometimes when we see blood pressure rises, I always ask, what's the heart rate? I have seen instances not with respiratory distress or shortness of breath, but I've seen patients where blood pressure rises a lot when they have a febrile non-hemolytic transfusion reaction. But almost always when that blood pressure rises like that, the heart rate jumps up quite a bit to match it. And so I always put that in context. And so, with that in mind, with shortness of breath and elevation in blood pressure, the next question that has come out is what's the fluid balance on this patient? And it turns out in this patient, they got 3 units of red cells over 2.5 hours. And I would argue even that's not enough. You want to dig deeper and say, well, was this patient actively bleeding? Because I've had patients that get 10 units in an hour, but I'm not worried about fluid overload because there's a big hole on the other side of some artery that it's all pouring out. Assuming that this patient was euvolemic or had no bleeding, that's a lot of fluid at once, and so that's a classic presentation of circulatory overload.
It is. It is. So how do you treat someone like
Well,
this?
it's supportive, and you try to diurese them. Sometimes what
Mm-hmm.
you have pushback from the team is, they'll say, well, how do you know it's the blood? Because sometimes it's just one unit of red cells and all this other liters of crystalloid. Things that have to come up is what was the patient's overall fluid status, and to remind folks that red cell transfusions or platelet or plasma transfusions are transfusions of a colloid solution, so it exerts a fair amount of oncotic pressure that's almost double to triple that of a crystalloid. And the other thing is, you just have to look at
Mm-hmm.
the fluid balance.
Yeah.
Weights are very good. Daily weights.
Ah, yes. Yes. Okay. Good tool. So, Mark, one more question on that. And I know you've already talked about it, but let's thumbnail it one more time for people, because this is something that people really struggle with. A quick and dirty. I know it's not always easy, but a quick and dirty differential diagnosis, or way to try and distinguish between fluid overload and transfusion related acute lung injury.
The thing to always remember as a thumbnail is they both can coexist. And the best solution I can tell, or the best tip I can give the audience, is you try to separate them out. So fluid overload, not always possible, but depending on the patient's kidney status, if they have hypertension with the fluid, obviously treat that and see if you get rapid correction of your respiratory status. If you do not, despite fixing the positive fluid balance, then I think you have to be concerned that you have acute lung injury on your hands, whether it's transfusion related or other comorbidities that led to acute lung injury, such as shock or sepsis. But that's the only way I think of trying to separate them. It's not always easy. I'm the first to readily admit that. Now, the flip side is if they're hypotensive, then, I got to be honest with you, fluid overload is off my table.
I think that's a really important tip, and I'm not sure that that's as widely appreciated as it should be, Mark. And I appreciate you pointing that out. That's really helpful. Okay, Mark, that's awesome. I appreciate you taking us through those. Those are 4 really common, well, not necessarily incredibly common, but at least common cases that people deal with all the time. But there are other cases, obviously, as you know, that are weird and rare. And you put together a list of 4 different cases that I wanted to give you just the opportunity to tell us what you might be thinking in cases like this, because it's really illustrative of some of the uncommon things that we might see. So you ready for me to fire these at you?
Absolutely.
Okay, let's do it. So here's the first one. A 2-month-old boy in open heart surgery goes into cardiac arrest after infusion of red cells.
Right off the bat, you're going to have to ask yourself, was this blood irradiated, which it most likely is? How long ago was it irradiated? How old is the blood? We're talking about concern for hyperkalemia.
Nice. Okay. All right. The second one, and we're just thumbnailing these guys, so this is just this real quick. The second one is an 80-year-old woman who received transfusion of platelets 5 days ago for some simple surgery, and now she comes into the ER and she has purpura and severe thrombocytopenia.
Absolutely. If you had to describe this is exactly as what you've seen it. Burn this into your memory, boys and girls. This is post transfusion purpura. If only exams could be such a gimme, but sometimes they are.
That's right. Couldn't get more classic than that. That is for sure. Okay, so here's the third one, Mark. So we have a patient with erythema. So he's got red skin and pancytopenia. He had a routine orthopedic surgery a week or so ago, and he was doing fine. And his dad, who's a doctor, calls you and he says, "What's going on? I mean, the blood is safe because I gave my son the blood."
So this is classic where blood relative. And you have to ask the question, did we fail to irradiate the blood because we are concerned with transfusion-associated graft versus host disease?
Yeah, again, a classic case. And here's the last one. This is an odd one too. So a patient who has severe thrombocytopenia, we don't know why, it's of unknown etiology, and he also has hemolysis and acute renal failure at the same time. Someone sees him and says, "Oh wow, he's got severe thrombocytopenia. Let me give him some platelets," and he develops stroke-like symptoms after that platelet transfusion. What do you think of there?
This is where you will need to teach your fellow colleagues in the hospital when they hear anemia, hemolysis, thrombocytopenia. think TTP, thrombocytopenic purpura. It's a relative contraindication, as we know in the past. Sometimes interventional radiologists will want a platelet transfusion anyway because they won't put a line in, but this is a medical emergency that requires emergent apheresis.
Yes, indeed. Just as an aside, I'm sure you've seen this, as have I. Everyone worries about this. I have seen many cases of this. Doesn't prove anything, obviously, but I've seen many cases of TTP where they've given the platelets and it hasn't caused any problems. But I fully agree that's not the right answer in those situations.
Yeah. It's a risk-benefit discussion that has to occur.
You're exactly right. All right, Mark. So, man, we have covered a lot, and I really think this is going to be of great benefit to my listeners. Is there anything else that you want to say before we shut it down?
Just want to say, thank you to you, Joe, for the opportunity, and thank you for your support of the community and the education all these years. Even I myself benefit from your notes when I studied for my boards. So thank you.
Oh, wow. Thanks for making me feel old. I appreciate that. All right. Mark, thanks very much. You have a great day.
You too.
Hi, everyone. It's Joe with just a couple of closing thoughts. I hope that was useful for you. We covered a lot of ground. I fully realize that, but I think what we tried to do is look at these things in a fairly structured way and to just give you some examples of how to work these up. What you'll find is that really the best way to do these is to see a bunch of them. Look at quiz questions, look at case examples. Mark has a little bit of a different way of looking at these transfusion reactions than I normally do in my teaching. There's a video on the Blood Bank Guy website where I describe kind of how I go over them. And my approach has evolved a little bit over the years. Doesn't make me right and him wrong. We both get the same place. We just go at it slightly differently. And again, that's totally cool. One thing I did want to mention, Mark had brought up the fact that he had developed kind of an extension or expansion on something that Nancy Heddle had developed previously on how to categorize transfusion reactions. We were able to secure permission from Nancy to utilize that categorization on the website. So if you'll just go to the Blood Bank Guy show page for this episode, which is at bbguide.org/podcast, you will find some slides there and some resources that, again, will help you to categorize transfusion reactions, hopefully in a better way. So thank you again for being here. Until next time, as always, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.